So thank you. Good morning, everyone. On this fellow stitching module, we are going to discuss a very interesting topic, a very challenging problem where we have dilemma and supracondylar humerus fracture is the most common fracture in pediatric patients. And every now and then we come across a pink pulseless hand. We know that the literature is divided, the consensus is not very clear, but to guide us through today, we have one of the most eminent faculties of POSI, Dr. Jayanth Sampath, my dear friend from Bangalore. He doesn't need any introduction. He is Secretary of Pediatric Orthopedic Society India as well, and bringing so many dynamic positive changes in the POSI, and I'm very happy to work with him as an EC member. Good morning, Jayanth.
Good morning,
and please enlighten us with this demanding subject. Please, you can share your screen. Thank you very much.
Sharing is not turned on.
Let me do this. Sorry. Okay. So, share.
I've just sent you a request.
No. I can share settings. Multiple. Rishi, can you do that from your side? You are the.
Yes, sir. I have done that.
Great. Thank you. So you can see my screen now?
Yes.
Great.
Perfect.
So pulseless supracondylar is something that is close to the heart of every orthopedic surgeon, and it certainly, disrupts our pulse from time to time. So why this talk? Why are we discussing this today? Because the supracondylar humerus fracture in a child is the commonest serious injury that we face. Of all the different fractures that we treat, this is the commonest serious injury. About 1/10 of supracondylar fractures have some kind of vascular impairment. And we will look at the different types of vascular impairment and how to manage those. And truth be told, most pediatric orthopedic surgeons cannot perform an arterial repair. So should something need to be done for the artery, we are relying on somebody else to come and do it for us. So that always creates some sort of anxiety, because then it involves time and relying on somebody else to do what is really work that we should be doing. But unfortunately, our training is such that most of us cannot perform an arterial repair. And any delay or indecision in this matter can have quite serious consequences for the child. So time is of the essence in managing these injuries. So our learning objectives for today are to look at the vascular anatomy around the child's elbow, look at how the pathology of supracondylar fractures influences this anatomy. What is a clinical setting in which children present to us with a pulseless supracondylar fracture? We have various diagnostic tests at our disposal and how to use them. We look at some common scenarios, treatment, and hopefully look at an evidence-based approach to current clinical practice. So the vascular anatomy of the elbow, everybody knows that there is a rich collateral supply to the main trunk of the brachial artery, which is a limb saver in many children. So this study by Lally, it was actually in a pediatric surgical journal, and in children with chronic renal failure who needed an arteriovenous fistula, this surgeon ligated the brachial artery in about 30 children and found that few functional problems were encountered. Some of them had some activity-related claudication type pain, but there was no serious impairment to the blood supply to the limb distally. So that's when people started to look at the importance of the collateral circulation around the pediatric elbow. The other aspect is how this vascular anatomy is arranged. And there is a particular artery called the supratrochlear artery, which is an anastomotic vessel that connects the main brachial artery to the ulnar recurrent artery, which goes posteriorly. And when you have a sharp medial spike, the supratrochlear artery basically tethers the brachial artery because it's a very, very short branch. And this is the main reason for the pulseless but perfused hand. And the anatomical basis for all the controversy is because there is a rich collateral supply around the elbow. It's also important to remember that there are no laterally directed branches of the brachial artery in the supracondylar region. They're all on the medial side. Therefore, a posterolateral displacement of a supracondylar fracture is associated with a higher incidence of vascular injury. So whether it's a posteromedial or a posterolateral displacement makes a difference to whether you will have a vascular injury or not. Now, in case you need to explore the artery, the supratrochlear branch can be ligated. And what that does is to release the brachial artery and allow it to be moved away from the fracture site or the fracture fragments. And when you have the fragment, the proximal fragment penetrating the brachialis muscle lateral to the neurovascular bundle, the brachial artery can actually get interposed in the fracture site. And during reduction, there are reports of the brachial artery getting incarcerated during the reduction. And that again can cause a problem. So you can have a situation where there was a well-perfused hand before the reduction, but after the reduction, suddenly the hand becomes white. So in those cases, you should always bear in mind the possibility that the brachial artery could have been incarcerated during the reduction. And obviously that requires immediate action. You have to remove the pins. You have to, redisplace the fracture and potentially open it in order to free the artery away from the fracture site. So because the median nerve, the anterior interosseous nerve in particular, and the brachial artery travel together as they cross the supracondylar region, there is an association between nerve injuries and vascular injuries. And many reports and series have highlighted that any median or anterior interosseous nerve injury increases the likelihood of some kind of vascular insult to the brachial artery. So when you have a combined injury, so when you have a child with a pulseless hand, along with signs of a median nerve or an anterior interosseous nerve palsy, pre-op, Harris and co-workers in their series showed that about a third of them will require vascular exploration. So whenever you have a vascular and a nerve injury, the risk of vascular exploration becomes very high. So that can guide your thinking as to how you want to organize yourself preoperatively, whether you would like to call a plastic or a vascular surgeon to come and help you out with those cases. So clinical examination is absolutely critical. You have to, as the operating surgeon, you have to examine the child personally. You cannot ask your registrar or fellow to shift the child to the OT and first see the child when they are under general anesthesia. That is unacceptable. So you have to see the child in the ER or in the pre-op area and document in your own hand what the findings are. You should do a primary and secondary survey. Supracondylar fracture with a vascular insult is a serious injury. Always look for floating elbow. Many of them have injuries to the forearm and wrist, which are frequently missed. So and with a child who is distressed and in pain, a senior surgeon should gently examine the child, but with some time and patience, you can elicit all the clinical findings. You should examine 3 nerves and 2 arteries. You should look for pulse and perfusion. You should check for a tense compartment. And in the fingers, look for the color of the fingers, the temperature, turgor in the pulp of the fingers, and the capillary filling should normally be less than 3 seconds. So brachialis sign, it's also called the pucker sign, is another important clinical sign which has been highlighted in the literature. Ho et al. In their paper said that severe swelling of the elbow, ecchymosis anteriorly in the cubital fossa, any tenting or puckering of the skin, or if you have an open fracture, significantly increases the risk of some kind of vascular insult. So let's look at, so this is a typical injury that you get, a type 3 stroke 4 supracondylar fracture. And that is the pucker sign, the brachialis sign. So here you know that the proximal fragment is tenting the skin because it has punctured the brachialis. And then we just do the milking maneuver to try and release the brachialis away from the fracture site. And then once you have done the milking maneuver, you can see that the pucker is gone. So if there is a pucker sign, it is better to release this before you even start the reduction maneuver. So the pucker sign is an important clinical sign which you can elicit, which may suggest a vascular injury. So as orthopedic surgeons, we have various equipments that are available to us, and we will look at these. But what you want is an immediate result that is actionable. There's no point having to wait for a long period of time to get a test like a CT angiography, which may take an hour or 2 to organize, and getting a radiologist in the middle of the night can be difficult. So you want something that's readily available to you, and you can yourself, as a surgeon, interpret the results of that test. So the commonest one which has been mentioned in the literature is the Doppler ultrasound scan. And based on the Doppler ultrasound, you can have a present pulse, which means on clinical examination and on Doppler, the pulse is there. You can have a diminished pulse, which means clinically the pulse is not palpable, but on Doppler, you're getting a pulse on the Doppler. Or it can be absent, which means both on Doppler and clinical examination, there is no pulsatile circulation at the level of the hand. So Weller and colleagues looked at this, and they said that if you have an absent pulse on Doppler, there is a much higher chance of arterial damage. So Rabi and co-workers looked at duplex ultrasound. The problem with duplex ultrasound is that you need a radiologist to interpret, and the advantage is that you get a 2D image of the artery, and you also get the pattern of flow. And we have something called a triphasic pattern and a biphasic pattern. The triphasic pattern is the normal pattern, and if you can see pulsatile flow with a triphasic pattern on duplex ultrasound, in case you have access to these facilities and they can be arranged in the ER, then you know that there is good circulation, pulsatile flow through the brachial artery. So Benedetti and co-workers looked at the CCDS, color-coded duplex scanning, and they also did ultrasound velocimetry of the digital circulation. And they found this to be quite a useful tool to determine whether there was a good distal perfusion. But in our own setup in India, we may find it difficult to get radiologists who can do this kind of high-level investigation on an urgent basis in the ER. But if such facilities are available, as a surgeon, you can. Angiography, I have just put it in just for historical reasons. It is not recommended routinely because it takes too much time and it does not really clarify the main issue for us. Sometimes it can actually confuse you and um, not, you know, based on angiography, it's very difficult for you to reach the right decision because you may just have spasm in the artery, which can mislead and misguide you in a tense moment, when you have a child with a white hand. So angiography is not routinely recommended. Pulse oximetry is a very simple and readily available tool which can be used in the ER and in the OT. And this has been looked at again in a large series of pulseless supracondylar fractures. And So and co-workers said that pink pulseless hand with a poor Doppler waveform could indicate true vascular injury. But if you have a well-perfused hand, you can use pulse oximetry even in the post-op period continuously. And you don't necessarily have to explore all hands or all fractures that have a poor Doppler waveform, because frequently, if you wait for a couple of hours and closely observe the circulation, in many of these cases, the Doppler waveform does recover over time. So the reliability and utility of pulse oximetry, though it is readily available, whether it really guides the need for vascular exploration in a perfused hand, in a pink hand, if you have a poor Doppler waveform, whether to explore that artery has been questioned by some authors. So I think if you are getting a poor waveform, but the hand is pink, just keep the pulse oximeter on the finger and closely make hourly observations to see if the waveform improves. If the waveform doesn't improve or if the perfusion of the hand changes, you can always change your mind and take the child back to the OT and explore the artery. So those options do exist for you in the post-op period. So in the ER, examine the child, as I said, and more importantly, counsel the parents. Tell them that there is a higher rate of complication in a pulseless supracondylar fracture. And explain to them all the different clinical scenarios that you may well decide to reduce the fracture, observe it, and 8 hours later take the child back to OR. That's perfectly acceptable clinical practice, but it is always good to inform the parents that all of these scenarios may exist, and it's important as a surgeon practically to have the parents on board when you're doing all these things. And you don't want added pressure from the parents at this time when you're making these critical decisions. So having a really open conversation with the parents pre-op before the index surgery is extremely important. You need to adequately resuscitate the child, perform orthogonal radiographs, and provide adequate pain relief. Splinting the limb is important. Typically, we do it in about 30 to 40 degrees of flexion. 90 degrees of flexion is not recommended in the ER. So if you have a badly displaced fracture, after providing adequate analgesia to the child, gentle traction to improve the position may relieve spasm in a white limb. And this is certainly a useful maneuver to do whilst you're waiting for the OT to get ready. You can do some of these simple measures. People have tried things like applying nitroglycerin ointment to the cubital fossa in an attempt to prevent or reduce the amount of spasm, but such measures have not really met with much support from the literature. So the most important and the most dangerous of these is the poorly perfused pulseless hand, the pulseless white hand. So what do you do with that? So the treatment is an immediate closed reduction and percutaneous spinning. Everybody is agreed that this is what you should do, closed reduction and percutaneous spinning, even if it is a white hand. And the pulse and the perfusion will return in more than 50% of cases immediately in the OR or within a short period of time, 15 to 20 minutes. the hand will become pink once you reduce the fracture. If the perfusion returns, you essentially observe the patient closely as an inpatient for a minimum of 48 hours. Because sometimes the perfusion can go out or they can have other problems like compartment syndrome, which needs to be closely watched for. So you are committing the patient to stay in the hospital under your direct supervision for 2 days. So you should look for return of radial pulse and also compartment syndrome. And you know that in children, we have the 3 A's, not the 5 P's: anxiety, increasing analgesic requirement, and apprehension. If you have an unsuccessful closed reduction, as in your closed reduction is, cannot reduce the fracture, you immediately proceed to an open reduction and vascular exploration. I put repair, but just an exploration and release of the brachial artery from where it is tethered to the proximal fragment may be sufficient in the vast majority of cases. So if there is no perfusion after a successful closed reduction, you still have to explore. So if you have an unsuccessful closed reduction, or if you have a successful closed reduction, but the hand remains white, those are the two situations where you have to immediately progress to exploration of the vessel. In a well-perfused pulseless hand, the so-called pink pulseless hand, there is no consensus in the literature, but there is bias certainly in the last 10 years towards observation only, and there has been a move away from exploring all of these elbows. So there are two broad schools of thought. The first is to explore immediately, and this group of surgeons can be called the Pulse School. So Blakey and co-workers from London, the Peripheral Nerve Injuries Unit in Stanmore, looked at the consequences of neglecting or ignoring a pulseless supracondylar. And because they are a tertiary unit, they got a lot of these cases referred to them a few days or a few weeks after the injury. And they had to deal with ischemic contracture and all the problems that result from not exploring a vascular injury in a timely fashion. And on looking at these 30-odd patients in their series, they found that increasing pain in the postoperative period or a deepening nerve lesion were certainly additional. In addition to perfusion, there were additional clinical signs that you could look for, which will help you to decide whether to do a secondary exploration. And the main thought behind the Pulse School is they want to prevent complications such as cold intolerance, Wolfman's ischemia, compartment syndrome, and in the worst case, an amputation.
Jayanth, what do you mean by deepening nerve lesions?
A deepening nerve lesion is when you have an anterior interosseous nerve palsy that then becomes a median nerve palsy. So you're starting to lose nerve function, whereas pre-op you documented that the sensation was there, and then 8 hours or 12 hours post-op, sensation that was previously present is going.
Okay.
So you are documenting on a regular basis in the post-operative period, and you are thinking that this is getting worse. So that would be a reason for you to take the patient back to OT. And that may actually be not such a bad idea, because then you have some time to plan, to call a vascular surgeon or a plastic surgeon to help you out. So these scenarios are, they are not by any means rare. They do happen. And as a surgeon, you need to be aware that it is not just a black and white situation. Do you explore the artery immediately or not? There are lots of other clinical scenarios that you will encounter as your experience increases over time. So keep all these possibilities in mind, and you can play around with them based on your local, whatever expertise is available to you locally. So the problem with immediate exploration is that even after a vascular anastomosis, reocclusion rates are high. And complication rates are also high, even in the group of children who had immediate exploration of the artery and some kind of vascular release or repair or whatever they did, still the complication rates were high. So why is this? How can we explain this high complication? Because we are exploring the artery to prevent complications. So why do complications still happen even in this group? So what is the explanation offered is that most of these papers are coming from tertiary centers, and typically these are higher energy injuries. And so this may be the supracondylar that required immediate vascular exploration may be a different clinical entity, a more serious clinical entity compared to the wing pulseless hand. So we may be talking about, apples and oranges here. So they may not be directly comparable. You have a different clinical entity. So that's something to bear in mind. So the other school of thought is the one where we observe the limb and don't explore. This is called the perfusion school. People who place more emphasis on perfusion, limb perfusion, whether the limb is pink or not, rather than whether the pulse is present or not. So the philosophy or the justification, the rationale behind the perfusion school is that spontaneous restoration of the radial pulse is common after a successful close reduction. And two explanations are offered for why you get the radial pulse back. The first is there is temporary arterial spasm, which is relieved by the close reduction, or it could be because of good collateral flow. And we know that both of these possibilities are quite common in clinical practice. So even if you have a successful spontaneous restoration of radial pulse after a successful close reduction, close inpatient monitoring of the limb for perfusion, pulse, and signs of compartment syndrome is mandatory in all cases. So the minute you have a limb that is being compromised in terms of its perfusion, vascular supply in any way, you are committing the patient to a period of inpatient monitoring. Do not discharge these patients from hospital on the same day or even the next day. Please keep them in hospital for at least 2 days. Now, return of pulse is not necessary for you to discharge, because once the limb is pink and you have confirmed that there is no compartment syndrome, the child is not in pain, and moving the fingers comfortably, we find that during follow-up, when we see them a week down the line, in most cases, the pulse has returned. So many complications happen whenever you have any kind of vascular insult, and these complications are present whether you do a vascular exploration or you observe them. In both scenarios, these complications can happen, and it's important for you to counsel the parents pre-op regarding this. You can have delayed vascular occlusion, which means you may have to return back to OT, which is rare but documented. Obviously, compartment syndrome and ischemic contracture are important problems to look out for. And late complications like chondrolysis of the distal humerus, osteonecrosis of the trochlea, or a physeal arrest of the distal humerus and a leg length discrepancy are all known and described complications. So this is a chart that you can look at. I'll refer you to a paper that I wrote regarding pulseless supracondylar fractures. So you don't have to memorize this chart, but certainly refer to it, because this chart gives you the most current or up-to-date guidelines for management based on the evidence. So have a playbook as a practicing surgeon. You need a plan that is based on what local resources are available to you, not what is available in the literature or in a research paper, but what is available to you. Chart out all the possible scenarios and have a plan. Can you manage all the possibilities in-house? And you need to have a very clear idea, and you need to be humble about this, about when to refer and when to treat in-house based on what your local resources are. So just to summarize, a pulseless supracondylar fracture is the commonest serious emergency in pediatric orthopedics. Failing to plan is all too frequent, and we do see these disasters from time to time, hopefully less in the future. Most pulseless fractures can be managed by an orthopedic surgeon, but timely access to some kind of vascular expertise is mandatory. Thank you. So this is the paper that we have published. It's in Journal of OASIS, the Orthopedic Association of South Indian States, and it's accessible online, and you can certainly go through it for further information.
Yeah, so it's a wonderful paper, and one more from Venkat, which published in, I think, in IJO or POSI journal. So Weber and Bipin, we have to get those articles on a fellows group. So it was a wonderful talk, Jayant, and I'm sure we have the highest attendance for many years now in this. So almost 65, 70 people attended. So I'm sure there will be a lot of questions. One thing I would like to tell, that puckering sign we see very frequently, but that does not mean um, vascular injury every time. But one has to be very careful, because puckering means brachialis interposition, and that is a severe injury. And milking maneuver, as Jan demonstrated, is very helpful. One thing is, when puckering is there, you don't feel the crepitus. When you reduce the moment the interposition goes, you can feel the crepitation of fracture fragments. Jayant, how do you use handheld Doppler in your practice by yourself?
We do, we do, and but this is basically, I use it as an additional supplementary tool. Um,
Yeah, how confident you are using that in dicey situations? I would rely more on my radiologist or a vascular surgeon to come in and see than myself. What is your
uh,
experience?
so I work in a tertiary center, so we have all of these people available to us 24/7, 365. So that's why I said that for you to be aware about your local facilities is very important, and to have good relationship, good communication, so that my plastic surgeon will turn up in the hospital if I call him in half an hour, because he's my friend. I know him. He will just drop whatever he's doing. If I call him, he will come, and I am confident that he will do that. So it is important for you to develop these relationships and maintain them should you need it. You will need it once in 5 years, but that single case once in 5 years makes it worthwhile to have a good relationship with a plastic surgeon or a vascular surgeon, pediatric surgeon, microvascular surgeon, hand surgeon. So many people are there who can explore an artery, no problem. There is plenty of expertise. So, and to have protocols in place beforehand. So you think about all these scenarios based on what is the setup you're working in, whether you're working in a city or in the periphery, what facilities are available. So if you're working in a peripheral setup, you have no plastic surgeon in your city or in your town, or at least one cannot be found readily, then you really need to think seriously. If you have a white hand, should you just put that patient in an ambulance and send that patient somewhere else? Do not be in a situation, the worst possible situation for an orthopedic surgeon is full well knowing that you don't have the facilities, just taking on that case and thinking, it'll be okay. It may not be okay. In most instances, it will be okay, but that small possibility is there, about a 30% chance that you may have to do something. And I think that's why clinical examination is very important, because that gives you a lot of clue. Even before you take the patient to the OR, there are a lot of clues there which you can pick up, whether there's a concomitant nerve injury, if there is a lot of swelling and ecchymosis, and it's a white hand, that there is a higher incidence of vascular injury. And if you don't have facilities, just send the patient. Don't be possessive about it. And or if you want to accompany the patient and be a part of what
Yeah,
happens,
it's a good message that if you do not have access to a vascular or a surgeon who can help you in repair, then it's better to send that patient to higher center. That higher center, they might just do the close reduction and the pulse may return, but that's fine, because in the case where it doesn't return, and you think that it needs a vascular repair, and sending a patient from one center to the other would be a problem. Now, Jen, I want to ask you one scenario. There are a scenario where the pulse was not there, the limb color doesn't look good. When we place the pulse oximeter, the waveform is not there. Now we have done close reduction, pulse has not come back. The capillary refill is doubtful, it's not persistent, and waveform is now like a little bit, but not much. Now I called hurriedly my vascular surgeon. He came and he said, how long you have reduced this fracture? I said, it's been 15 minutes and it's still not come. Then he said, you wait for an hour because this can just be the spasm. Bring the patient out of anesthesia, let's watch, and I'll come back after 2 hours and have a relook. And there are a couple of scenarios, 2 times it happened so that after an hour, everything came back. The limb turned pink. So he told me, you in those scenarios, you don't jump for vascular repair right away and wait for some time because of the maneuver we do while reduction can keep the vessel in spasm. And it's not necessary to do vascular repair if your close reduction is good in the same anesthesia setting. And that happened twice. And I was worried that how can I take this patient out of theater? And he said, I'll come back and review and just tell family that we might need to explore if it doesn't come back. And 2 times it happened so that it returned. So it is a little different than what we are practicing, What do you say about it?
So I have also encountered this many a time. And you have to wait. I agree with your vascular colleague that I have waited for an hour. I have even missed a flight because I thought the pulse will come back and the pulse did not come back. So I have waited for an hour in the OT. And all I have done is told the anesthetist to slightly reduce the anesthesia so that the systolic BP goes up a little bit. But still kept the patient with a tube in the OR with a pulse oximeter just sitting there patiently. And I do things like put a warm saline mop in the cubital fossa, trying to relieve that spasm. But I've already informed my plastic surgical colleague saying, be ready to get into your car and drive towards the hospital should I request you to. So that I have explored the artery in the last 15 years around maybe 3-4 times. So it's a very rare event. So we do about, 50 supracondylar fractures a year. So we are not as much as American units, but we do a fair few of supracondylar fractures. So
usually the complicated ones are referred, when the surgeons see that there's no pulse, then they say go better to the bigger center or something, So
yeah,
so more of a complicated version.
I think I agree with you that you can wait for up to an hour. If you see some improvement, that things are slowly coming back, it can take quite a long time, and it's important not to shift the patient out. Keep them in the OT and make sure that before you shift them out, at least you have a perfused hand with some kind of Doppler waveform. I think those two signs would reassure me that I don't have to do a vascular exploration.
Another scenario I want to tell you, one of my adult orthopedic surgeon colleague with a huge volume. Now he got a supracondylar, and it was pink, and he could feel the pulse. Pulse was a bit not very bounding, but feeble. The moment he tried close reduction, the pulse went off, and the hand turned white. And the moment he is extending the limb, the pulse comes back. So he called me, what should I do? I said, you do open reduction and make sure that the brachial vessel. And he said, I'm not capable of doing open. I have not done open reduction from front. And patient was already under anesthesia. So I was busy in other surgery. So I could not answer anything, but I said, if that is the scenario, say you wait for some time and try again. And he waited for half an hour, he tried again. Again, the same thing is happening. So what he did, he kept the limb in extension. He looked at slab, the position where pulse was coming, and he waited for edema to come down. And in 2 days, he went back. The edema was little less, and he could do successful close reduction now. So he said, I tend to do a delayed fixation in such scenarios, which was again a bit offbeat from what our text explains. What is your take on this?
I mean, it's anecdotal, and I feel that
Ah,
surgeon was lucky, because I certainly would have a very irate parent if I said that I'm just going to not reduce it.
mm,
I think every pediatric orthopedic surgeon should have the skills to open a supracondylar. We should have that. It's an essential skill.
like we know, but all the adult orthopedic surgeons, they should be well versed with anterior approach. There's no need to fear. And if you're doing huge volume of supracondylar and complex trauma, you should be able to do anterior approach. Now let's take some questions. Then my voice is probably breaking. The first one is, if there is a pulseless pink hand after a close reduction and pinning of a supracondylar fracture, how long do we observe the child uh, on the ward after pinning? What is the protocol? I think you explained already, but can you go through it again?
So the um, recommendations, the guidelines are that they should be in hospital for a minimum of 48 hours. Some authors keep them for up to 72 hours. And you have to do, don't elevate the limb. Just keep the limb at the same level as the heart. Encourage uh, regular finger movements to reduce swelling, and make sure the child is well oxygenated and well hydrated. So things like IV fluids and having adequate analgesia, and you're basically watching for the perfusion to remain, number one, and number two, you're watching for signs of compartment syndrome. So in compartment syndrome, we have the three A's, not the five P's. So we have anxiety, apprehension, and increased analgesic requirements. So you should examine the child and make sure that they don't have any stretch pain, and you're not, child is, and a child with compartment syndrome will just be screaming. How much ever painkiller you give them, they will not let you touch the hand. So it's a child with a compartment syndrome is pretty easy to diagnose clinically. Now, another point which I did not mention in the lecture was, if you are doing a repair of the artery, you should decompress the compartment. So you should do a compartment decompression at the same time. I didn't want to go into the details of it because we don't repair arteries. It is the work of somebody else. And but any plastic surgeon, they are trained to do a decompression at the same time, and you can just do a simple scissor fasciotomy. You don't have to make a huge, because there's a prophylactic fasciotomy. So all you need to do is just put a scissor down the forearm volar compartment and make sure it is released.
So if there's an established BIC, then you do an anti-Henry's approach and you do the
Yeah.
compartment opening, but not, it's a prophylactic fasciotomy you can do percutaneously. Sham, do you have any question, please? Go ahead.
Yeah, nice talk, Jayanth. I hope you can hear me.
Yes.
So, couple of things. Compartment syndromes, a good neuro exam is really important. And I think you stressed this thing because a median nerve palsy, as opposed to an AIN palsy, will mask the compartment syndrome. And so, if you have a volar compartment syndrome and the patient has a median nerve palsy, you can be lulled into a sense of false security because they don't have sensations. So that's one. I have had the misfortune of having a patient who had delayed brachial artery thrombosis after a type 3 supracondylar fracture, and presented to the clinic a week later with dense three nerve palsies, all three nerves out. And so these, when I talked to Waters, he said there's only another case he was aware of, and that one required a transforearm amputation. So these, while they are so rare, I think it's important to be wary of these. And I think you stress the right thing that if you don't have the support, if you don't have the tools you need, pack the patient off as soon as possible to somewhere that they have that ability to do it.
Thank you. So, Shyam, what was the outcome of that patient? Did you have to go and decompress? Did it work in a delayed setting, decompressing the compartment?
No, no, it was not a compartment syndrome. This kid actually ended up, we think it was ischemic neuropathy. So
Uh-huh.
she looked like VIC, the appearance, but it was a pan neuropathy. There was no contracture. You could stretch all the fingers out, all of it was fine, but she had no pain, nothing at all. And she presented actually to see my nurse practitioner at a week, and that was missed at that time. And she came back to see me for the pin pull. And I was a little surprised because she had petechiae on her fingertips. And I was
Mm.
like, where, like these little embolic spots on her fingertips. And that's when I have a Doppler that I used, and there was a, block. We got an angio, and there was a 4 centimeter segment of brachial artery that was solidly thrombosed. But at that time, she was embolizing from that.
Uh-huh.
So, yeah, so it's very rare. It's extremely rare injury. And we thought that the working diagnosis, after talking to a lot of hand surgeons and people around, was she may have thrombosed off the vasa nervora, resulting in the pan neuropathy. It's just so unusual. The other point that I didn't discuss earlier, which you haven't talked about, is the local anesthetic use and papaverine. So we have papaverine available in the OR. Papaverine is a very powerful vasodilator. And if you're going to open it, so, in the cases where I've had the brachial artery interposed or incarcerated, and it just needs a very simple approach. I mean, you actually go where the skin is dimpled or where the bruise is. That's the easiest way to get to it. And just go very carefully because the artery is going to be right under the skin. And then once you expose it and release it, I use an intraoperative Doppler. And if there's very faint pulse across that, just take a cotton pledge jet, soak it in papaverine, and just put it on the artery and let it sit. And again, the other thing that you can use is just regular old local anesthetic, just lidocaine or bupivacaine without epi, because they are also very good vasodilators.
So the reason I did not include any of that is because this is a fellows teaching module. I did not want to mention any of these things to the fellows. So I wanted to keep the lecture at the level of clinical examination, decision making, and what is the evidence saying. Because
Fair enough.
once we become experienced orthopedic surgeons and we have the experience and the skills to be able to negotiate all these difficult scenarios, then all these practical tips are certainly very useful, and I use them in my clinical practice as well. But that is only when you have a good setup and you have a good grip on things and you really understand the problem. So that's the reason I could have easily put in some slides of how to do a vascular exploration and all that, but that's a totally different. You're moving into a different territory,
Right,
and
let's have one question. Does AI and palsy change the management? So for instance, there is an AI and palsy and there's a pink pulseless hand. Would it
so
change your plan of management?
yeah. So there is one paper frequently quoted by Mangat from Birmingham, which said that if you have a median nerve palsy along with a pink pulseless hand, the rate of um, requiring brachial artery exploration is higher. But I think there are there is enough literature after that paper, to say that so long as the hand is well perfused and there is no compartment syndrome after the reduction, there is, just because you have an AIN palsy does not automatically qualify the patient for an exploration. You can still wait so long as perfusion is good. So a poorly perfused hand is always an indication for exploration. A well perfused hand is an indication for close observation in the post-op period. Those are the only two clinical scenarios that result from a pulseless supracondylar: close observation or exploration.
Now, we have one interesting case from Vidyasagar. Actually, Vidyasagar is operating. So, Vaibhav, would you like to share your screen and you can present that case? We have Shyam and Jayanth to help us with. Yes, Dr. Udaya Kumar. All the residents and students can always attend this module is for them only. So feel free to make them part of that group, and they can always attend. Yeah.
So Dr. Uday Kumar is actually the teacher and mentor of my fellow, Dr. Pramoda.
Okay.
And Dr. Pramoda basically sent the link to Dr. Uday Kumar, and I think many of his students have joined us for the
Yes,
teaching
sir.
module today. And it's
Thank you so much, Sampath sir. Thank you so much.
Yeah.
And Maulin sir also, I met him in 25 years back in Mamalapuram, Chennai.
Yeah.
At that time, sir has given a talk on the pediatric proximal neck humerus fractures.
Okay.
I still remember that talk, sir. You gave me your card also at that time in Mamalapuram. Maybe hope you remember that sponsored
That
program.
was the time when I used to carry my cards. I don't have cards anymore. Anyways, thank you, sir. And all your students can always attend every Saturday morning. We have very interesting sessions.
Thank you so much, sir. Thank you, sir. Thank
And
you.
you can present your difficult cases as well. Can we use one K wire through olecranon for temporary reductions, removing at end? That's an supracondylar reduction talk. Yes, we can use different, what you say is a joysticking maneuver. But besides KY, you should use a blunt instrument like an artery or a dura. That would be better because your KY can injure the closely lying vessels. Yes, Vaibhav, please go ahead.
Is my screen visible?
Yes.
it is.
So, yeah, good morning, everyone. This is a case of 7-year-old girl, a boy, presented with a history of road traffic accident and at 8 p.m. in the evening. So this was clinically how the limb looked. On physical examination, there was obviously swelling in arm, elbow, and wrist. There was no distal pulse. The hand was pink. There was sluggish capillary refill, some irregular waveform, and SpO2 was 80 degree, and there was AIN palsy noted. X-rays revealed distal radius fracture, supracondylar fracture with concomitant ipsilateral shaft humerus fracture. So this is the clinical picture. So I would like to ask, how will you proceed with this case?
So this supracondylar was open, there was puncture wound or was an open injury?
Yes, sir.
At the
There was
level
puncture wound on anterior surface.
Okay. Yeah, Jayanth.
So no question. So no question about it that you need to. It's an open fracture. It's a high energy injury. So you have to do an open reduction of this because you need to clean out the fracture site as well. So I would use a transverse incision in the cubital fossa and directly bring the fracture fragment out and do a proper debridement, washout, and stabilization of all three fractures. I'd probably pin the supracondylar and just pass the same wires a little higher into the diaphysis just to hold the humerus fracture and, close reduce and percutaneous spinning for the distal radius.
You can do in different orders, Vaibhav. You can reduce the radius first, and you have an AP view of wrist.
No, sir.
But I would fix the radius safeguarding the physis in this case because there are multi-level injuries. I will put one wire, and after fixing that, uh, we'll do the debridement. Now for open grade 1, where the fracture looks, you don't need to open everything, but you just do a local debridement and you pass 2 long K wires. Maybe you might need 9 inches K wire. Your 6-inch K wire may not go through. Many times you may use cross pinning distally and pass 2 more wires route down the proximal humerus, but multiple wires can induce stiffness along the elbow. So I'll agree with Jayanth. Any other comment?
Regarding the pulseless part, obviously you have the fracture site open. That is most likely the region where the brachial artery has been injured.
But
So
hand is pink, it's a pink pulseless hand. So would you explore or would you wait? I would just.
No, I mean, because you have it, because you're going to expose the fracture site for the open fracture anyway. So, in an opportunistic manner, you can just have a look at the artery as well.
If it's just a puncture wound, then also you will open the fracture completely, Jan?
I would, because it's a road traffic accident. It's a high velocity injury. So,
right.
So I would make a generous incision and wash it out.
Perfect. Any other opinion?
I actually this is Sham. The supracondylar fracture does not appear terribly displaced. I wonder if it's a distal radial fracture that's creating the vascular issue for the hand. So I would reduce that ASAP and then reassess the elbow. If they're your grade 1 opens, I have not been very aggressive about opening it. But when I open them, the only difference from Jayanth is that I tend not to make a completely transverse incision. I tend to make it extensile so I can follow the brachial artery up and down if I need to. So maybe just a short bit transverse in front of the elbow, but a longitudinal bit going up. So it's like a Z incision, like a Z incision. That's the only difference. But I agree with everything else.
Yeah. So you would pass those wires approximately and hold the humerus straight.
Yeah, absolutely. Yeah.
Perfect. Yeah.
So I have a question. Is it a typical pink pulseless hand? Because the hand is pink, but there are some signs. SpO2 is 80%, irregular waveform, sluggish capillary refill. It is not a typical pink pulseless hand.
Yeah.
There is so
you will reduce, and there is high likelihood that you will see a good waveform on pulse oximetry, and you will feel the pulse volume might increase.
okay.
So you will reduction, yeah.
Since AI and palsy was there, we went ahead for a Doppler, and Doppler revealed no flow in the ulnar and the radial artery, and there was no flow from the supracondylar region in the brachial artery. So in that respect, we went ahead and fixed the shaft of the humerus first with a plate, and then the supracondylar was just a second. Yeah, the supracondylar was opened from the anterior approach, and the brachial vessel was punctured, and it was repaired with the vascular grafting. So this was the scenario, and yes, post-op pictures. Shaft humerus was fixed with this supracondylar cross pinning was done. It was anteriorly displaced the shaft. It was completely type 3 Gartland type 3 fracture, and the distal radius was fixed with intrafocal pinning.
So this is a very good illustration of how, when you discuss the case in the cold light of day, you will reach certain conclusions. But then when you're actually the treating surgeon, with a child with a slightly compromised limb, you think very differently. So, and that is something I've seen on a number of occasions, even my own cases. When I do it at the time, I'll do something, and then during post-op follow-up, I'll have some other thoughts. So this is quite common. I mean, he has plated the humerus. I don't know why Vidyasagar plated the humerus, but I'm sure he had good reasons at the time why he did it. So, I mean, I think it just highlights the fact that, if it's an open fracture, obviously very severe injury to the limb, broken in 3 places. So high index of suspicion for a brachial artery injury. But having said that, see, just because you have a brachial artery injury, many of the pink pulseless ants actually have a compromised brachial artery, and they're all surviving on collaterals. And that is okay. That is the main message from the literature, is that don't go looking for, do Doppler and find out is the brachial artery patent or not. So long as the distal perfusion is okay, so long as the child doesn't have compartment syndrome, the pulse eventually returns. In the vast majority, like 99% of cases, by 6 weeks, the pulses return. And many of them will have spasm, some of them will have thrombosis, intimal tear. If you go start looking for these things, you'll end up exploring a lot of them. So don't go looking for trouble. Just check the perfusion.
Yeah. So what Jayanth wants to mention is you still reduce it and see if the circulation comes back, and if it still remains doubtful circulation, no pulse, and then it becomes an indication of calling in a vascular surgeon. Probably Vidyasagar fixed humerus because he would have expected that he will need to do observation of the wound. And so at that time, if humerus is free, then it would create a problem. Yeah. So what is important is what happened with this child on longer term. Do you have long-term outcome?
Yeah, so basically, his hand function was absolutely fine, and the fracture healed well. This is the 6-month follow-up X-ray in which supracondylar and the both shaft of humerus healed well. Yeah, I have
So
these.
can you go back? What was the reason? Some fasciotomy or what? Can you go back to the present? I saw at some point some area was sutured and some also did do some fasciotomy. If you have that information, otherwise it's okay.
No, sir.
Yeah, so it was a very severe 3-level injury, and these children have a higher chance of developing compartment syndrome. So it needs a vigilant observation. But it was nicely managed case. When everything ends up good, it's a good case. So I think, and that was a very nice talk, and lots of people attended your talk. So the 2 things, it's a very interesting topic and it's a very popular faculty. The 2 reasons. So it's for your time, and we will pass on these papers you quoted. The fellows will post them on the group. Thank you very much.
I would certainly recommend reading the literature, at least some of the review articles, because it really tends to clarify a lot of the gray areas. So reading papers, I think, is the best way to try and best deal with these problems. And there are many good papers. So you can use my review article as